Let's do it.
Welcome back to the Sickle Cell podcast. It's Cass here, and I'm honored to be joined by a very special guest, Dr. Julie Kanter. She has devoted her career to improving care for individuals living with sickle cell disease across their lifespan. So one of the reasons that I'm particularly excited about this conversation is because there's a reality that we don't talk about enough within the sickle cell community. And we know that pediatric sickle cell care comes with structured support, dedicated resources. But unfortunately, that support doesn't translate over always. And usually there's a significant decrease once a sickle cell patient transitions into adult care. So this is often referred to as the point where things fall apart and adults with sickle cell disease find themselves navigating this complex, evolving condition largely on their own. As we know, sickle cell is unpredictable. It keeps you second guessing. And I'd argue that it gets more complex as you age. But as an adult, I would like to also argue that we need just as much guidance. We need just as much advocacy and thoughtful care as kids do with sickle cell. So today we're diving deep into adult care for sickle cell. Before we get started with some of our questions, Dr. Kanter, could you please tell us a little bit about your background?
Sure. So I'm Julie Kanter. I'm the director of the Adult Sickle Cell Disease Program at the University of Alabama in Birmingham. And I co-direct our Lifespan Comprehensive Sickle Cell Center with Jeff Liebensberger, who runs the Pediatric Sickle Cell Disease Program here at UAB. I have devoted my career to sickle cell disease, really been focused in sickle cell disease since I started faculty a long time ago. And small secret, I used to be a pediatric hematologist. And what I realized in doing that was what we needed to do better, both in pediatrics and as people got older. And so I transitioned myself to adult care with additional learning. And I'm also the president of the National Alliance of Sickle Cell Centers, where I am really proud of the work we're doing to help get the community, the country, that specialized care they need regardless of age. And that really is the job of our alliance, is to identify, support, and sustain new sickle cell centers.
So our rapid fire question, we usually ask this first question to whoever we're interviewing. Why sickle cell? And that comes from wanting to understand better how to pull people into this community. So why sickle cell?
So my favorite sentiment came from Dr. Ekman, and he said, it gets in your blood, which was a fabulous and perfect pun. Why sickle cell? So when I was getting into medicine, I did a early internship in my first year of medical school through a series of connections with a physician, really second year, who allowed me to join his hem-onc clinic. And that's where I got my first sort of taste as to what that even meant. What was hem-onc? And like most, I think, medical students, I came out of that clinic and was like, of course I'm going to do oncology. Doesn't everybody want to do oncology? And sickle cell had a prominence, but it was not the day that I went to clinic. It was not a sickle cell day. So I saw very little sickle cell at that time. And it wasn't until then I got to residency and eventually fellowship. I always wanted to pursue areas that perhaps not everyone was focused on and ask the questions that people hadn't asked yet. And so originally my quest in oncology was to improve the post-cancer experience, because everybody focused on treating someone and they didn't focus on the person that was left at the end. But then I realized once I was a fellow, I was horrified at the number of opportunities, treatments, everything that I could offer a child with cancer that I could not offer a child with sickle cell disease. And that's what started to really change my focus and how I wanted to dedicate my work life. And then it was really framed by two individual patients that I took care of during my time, and they just taught me that we really needed to do better, be better, ask better questions, fight for better answers, find better resources, identify new therapies. So by the time I finished fellowship, I was gung-ho sickle cell disease. And then as I became an early faculty in pediatrics again, I realized that while the need in children is certainly important, the need in adults is so much greater. And I also learned if we don't do things right in pediatric care, you don't get to start off on the right foot in adult care. And I think we've made that mistake for a long time. And we didn't mean to, we as doctors, but now we got to walk backwards a little bit to right some wrongs and improve adult care.
We're here to talk specifically about adult care with sickle cell disease. Without any strings attached, what is your initial piece of advice you have for adults with sickle cell?
Find a sickle cell specialist. Sickle cell disease is a very complicated disease. I talk about a lot how much more complicated it is than we used to think. We used to think, oh, just a blood problem. And now we realize it's so much more than that. As you stated earlier, it gets more complicated as people get older. We're all like fine wines, right? We all get better and more complex as we age. And there's just so many nuances that if you don't have a specialist to know how to see the patterns in you, the individual, as opposed to the population, you really won't get the best care. And so one of the things we really advocate for is, my goal is, at least the way I think of it as part of NASCC, is to figure out how to get a sickle cell specialist to you. And we want to help you find the sickle cell specialist.
Yeah. And of course, you can't do that if you don't have a home hospital. So walk us through what it means to have a medical home and why it's so important for adult care in sickle cell.
I do think it's really one of the most important things we can do to improve quality of life and quality of care. Sickle cell disease, one thing I think a lot of people don't understand is there's a lot about patterns. And what I mean is, because you are such an individual, your labs, your pattern is going to be different than somebody else. And the other reason I think individual and annual or 2 to 3 times a year care is so important is it helps me establish that pattern so that when your labs are completely out of whack, I know. And that's going to be different for you than it might be for somebody else. And if you have your home hospital, they can see that. It's glaring. Whereas otherwise, I'll give you a great example. I have a patient that I take care of with hemoglobin SC disease, and her normal hemoglobin is 12. She went to a hospital recently and saw a physician, and her hemoglobin at that time was 8. And they didn't know her, didn't have her history to know, wow, that's really worrisome. Her hemoglobin's so much lower than baseline. They just said, oh, she has sickle cell, 8 is normal. And so those kind of discrepancies are only seen at a place that knows you as an individual. And so the more you can be seen within your own system of care, the better care you're going to get.
Makes sense. And for somebody who isn't part of a medical home, how do they find a sickle cell specialist and where do they start?
www.sicklecellcenters.org. I'm pretty excited, right? We have sickle cell centers now, peds and adult, in every state with the exception of Wyoming and Montana and North Dakota. And if you're in those states, call me personally and we'll figure something out. There's not very many people with sickle cell disease in those states, but those are our states that we're still lacking for centers. But sometimes that doesn't mean that you can get to that center easily. But it doesn't mean you can't call them and say, hey, could we have a virtual appointment and set up a plan and help me work with my local doctor to do something? And I think that's what our next step is in the Alliance, is how do we bridge that gap to affiliates? And it can be done in a lot of different ways. I often see people by telehealth. And as long as they're in my state, that's still allowed and available. And then I'll call their doctors where they are and say, hey, let's work on XYZ together. And that's been really effective. But it does take a little bit more, either a physician like me, I guess that's my goal, is to increase this access to care, or a little bit on the patient side. If you're the individual and you're like, hey, I really want to see you in Birmingham, but I live in Dothan, Alabama. How can we navigate that? What can we do?
I always want to put a global lens on this. What advice do you have for people who might not be within the US to find a sickle cell specialist? Understanding that places differ in terms of care. For example, somewhere like in Canada, receiving care or finding sickle cell specialists, what would that look like?
So I think that's a really good question, and something we need to work with our global groups to do better is identify those resources. It's not always easy. And, I've had people call me from Pakistan and say, can you help me find a doctor? In Pakistan, I will tell you, it's incredibly challenging, but I was able to connect to somebody else who knows somebody. And then we were able to connect that person. And so I think there are ways to get there. I think there are people everywhere who want to help people with sickle cell disease. And it's a matter of finding the right person and connecting the dots. It's just that sometimes it takes a little more work than others.
At the very basis, it requires reaching out to somebody who works within the space. For somebody that's in Nigeria, for example, looking to find somebody around them, finding an individual and asking to get a better understanding of resources around you.
And definitely look up community-based groups in your area. We have amazing community-based organizations like Sickle Cell 101 that have all these resources. So I think there are people who are available to help you, and it's just a matter of sending an email. And I get these emails all the time, hey, can you just help me find somebody? And don't be afraid to send those emails.
So you have a sickle cell specialist. What could be the difference between seeing a hematologist and a sickle cell specialist?
So a really good question. And then the next question that everybody's going to ask is, how do I personally know the difference? That's a hard question. We have a whole list of criteria that would tell you what a sickle cell specialist is. So you certainly could take this list that will soon, I hope, be published and say, hey, can you do X, Y, and Z? Are you familiar with X, Y, and Z? And that is one way to do it. If you are talking to a hematologist who's not familiar with the unique blood transfusion needs of somebody with sickle cell disease, that would worry me. If you're a sickle cell specialist and use the same dose of hydroxyurea for everybody, at least in the United States, that would worry me. And I've seen a lot of this in the community hematology space. I often find, though, if you just ask the person, they're also going to be really willing to tell you. This is unlike other areas of sometimes medicine where there's a lot of ego. I have found from my community colleagues, they're willing to say, hey, you know what, I might not be the most knowledgeable person in the room. Let me connect you to somebody who is. And that can be really helpful. And so I think that's another really good option, is just ask your doctor, how comfortable are they? How many people do they take care of? And do they feel like there's anyone else you should talk to?
One thing I've learned just throughout the work is not every hematologist is specialized in sickle cell. And so I think people often see the word hematologist or hematology and think, oh, they can treat sickle cell. Are there any other considerations?
So I'm going to tell you the flip side is true too. Not all of our sickle cell specialists are hematologists. And so, one of the other things that we are working on implementing, i.e. funding at NASCC, is a sickle cell specialty program, because we want more specialists, and we don't believe you need to be a hematologist. You need to gain sickle cell specific hematology knowledge. And then you need to know who to call if something comes up that you don't know anything about. And even for me, like I had a patient who their labs looked very, very off, and it wasn't consistent with sickle cell disease. So I called another hematology colleague. Unfortunately, that patient had a cancer, but it was a matter of making sure that I know who to call and I knew what I didn't know. And so I think that's also really important. Again, I think you can look at all the sickle cell centers. To be a NASCC recognized center, you have to be led by a sickle cell specialist. Doesn't have to be a hematologist, but it has to be a sickle cell specialist. And so you can always call there and figure out that one way. And again, I think the rest of the time, it's just asking your doctor how comfortable they feel.
Absolutely. And I think what's great about this particular conversation is the fact that, like you said, not every sickle cell specialist has to be a hematologist. I saw a great sickle cell specialist at Children's Hospital Oakland, Dr. Keith Carollo, and he was a pediatrician by training, and he just had interest within sickle cell. And sometimes that's all you really need. There's such a shortage of hematologists and such a shortage of adult sickle cell specialists that whoever shows interest and has that training is somebody who can treat you with sickle cell.
And I think they can develop the skills if they're missing them. I think for me, and I tell people this a lot because sometimes they don't believe me, but what makes me, to me, the best doctor I can be is knowing what I don't know and knowing when to ask somebody else. And I think that's something all of us, right? That could be true of anyone about anything. And I sometimes find that hard for physicians to acknowledge. So another idea that I came up with and we're trying to figure out how to operationalize is the Alliance has recently put together, through a couple of years process, some enhanced screening recommendations. So it's not, right, what do you need if you're an adult living with sickle cell? We need a doctor, but you need the doctor to do the right things. And usually they're the same, but maybe not always. And one of the things we learned early on when we were teaching people how to take care of people with sickle cell is they needed more data. They needed more checklists. and they didn't exist. So we created one. And what we want to do now is make sure that we bring it so that every individual living with sickle cell disease has their own copy of what they should get every year. Because that way, if you're seeing someone who maybe you're not as comfortable with, you can be like, hey, this is what the Alliance says I need every year. And then have a conversation. It opens something up. And usually it goes pretty well. And I've had this experience. I only take care of a couple of people with beta thalassemia major. Where I live, we don't have a ton of people. Now, I take care of anybody here, but there's just not a lot of people with thalassemia in Alabama. I am not the most knowledgeable expert in the room, and there is one in Atlanta. So I have a patient who goes every other year to Atlanta to make sure that I'm doing the right things and sends me back with a list of things that need to be done. And I love it. I think it's great. And so I think having those collaborations is huge.
That makes perfect sense. And just to get started, something glaring within adult care with sickle cell, it's going to the ER. And you touched upon how important care is for adults with sickle cell. But then within the ER, what should good care look like for an adult living with sickle cell?
I mean, I think the most important thing is to have a doctor and a team, right? As much as ideally, and sometimes we don't have the luxury of a full team, but you know how to get to the people that you need, or the doctor can get you to the people that you need. And with that, and I'll take UAB as an example, until we had a sickle cell program with me here, people would go to the ER and I thought our ER overall did a decent job. They got people in, they got them treated, they admitted more than they didn't. What they didn't do is have any individualized care plans, and they didn't know how to treat certain individuals differently, or what to look for, or how to recognize signs of impending doom, as I call it, or badness. Or on the flip side, sometimes they didn't even recognize when people didn't have sickle cell disease, because you'll have people who come to the ER and say they have sickle cell, and they don't. And so all of these things together make it very hard and challenging on the ER doctors. And so when we put together individualized care plans for each individual patient, that meant that it helped individualize the disease. I think for ER doctors who see a population and don't always see the individual, even without looking at what the meds were, it was just knowing that here they were treating a patient and that patient had their very own plan. And that was a huge difference. And the same thing happened in the hospital as we slowly made sure to increase this care into the hospital realm. And then, of course, our biggest goal with good care, if you're really doing well, you shouldn't have to be in the hospital. You should really not be in the hospital very often. And if you are, it's a random one-year event. And the people that I take care of that are really doing well, the biggest problem is I can't enroll them on any clinical trials because they're doing so well. And that doesn't mean that I don't think they need improvements in their care. It just means that they're not having frequent pain events that are what right now, unfortunately, are often the key to clinical trials.
And you mentioned individual care plan. Can you speak to that a little bit more? I'd like to bring to light in regards to individual care plans is a lot of the experience for people who do have individual care plans and they bring it to the ER, they get disregarded. Can you share a little bit more about both of those?
Yes, absolutely. So the individualized care plan is about pain, but not only about pain. So it has usually, if they're well written, for me, it has to be short and sweet and to the point, because that's the only way you can get an ER doctor to read it. So I try to have your sickle cell disease genotype, warning signs about you. This person never has pain. If they have pain, it's a real frightening concern. Address immediately. This person cannot be transfused. They've had a terrible transfusion reaction. Those kind of warning signs that I want them to see right away. And then I include the pain plan. And it might be when Cass comes to the ER, she needs Dilaudid 2 milligrams IV every 1 hour for 3 or 4 doses, and then reassess. She needs Zofran. She needs some oral Benadryl for her itching. She needs this much fluid, not too much fluid because we have that problem. She does well with Toradol, and then reassess and decide if she needs to be admitted. And then transfusion recommendations specific to that person. And that's it. I try not to put their whole life history because the ER doctors won't read it. Now, that being said, if right now the way things are, if they went to an outside of UAB hospital, I can't promise that plan will be seen or evaluated. And until we get better interoperability, it's a problem.
What would you advise for somebody who has taken the time to put together an individual care plan, and it's just not being acknowledged. What can somebody do within that situation?
One thing that I found really important in our system was when I got here, I've been to a few systems now, and when I got here, I went to the ER doctor before I ever put an individualized care plan in the chart. And I went to the whole department and said, here's what we're going to do and how we're going to do it. And it has to be that kind of top-down message. And it was not only well received, it was very well received. I think people say, oh, the ER won't listen. The ER wants to know exactly what to do to make you feel better. That's why they're doctors just like the rest of us. But they often don't know. And so it was very well received, but it had to be done at kind of that systems level. So for someone who's in their own hospital and their care plan is not being observed, I would go back to the doctor and say, hey, how can we change this? Can we go talk to the head of the ER together?
I anticipate that a lot of what you said resonates with people. So if they wanted to get connected with you, what is the best way?
jkanter@sicklecellcenters.org.
Thank you so much, Dr. Julie Kanter, for having this important conversation today. Accessibility is huge for us, for you to be able to come here and share your expertise with a broader audience. It really means the world to someone like me, and I'm guessing people who will listen. So I appreciate you taking the time to have the conversation.
My pleasure, and I appreciate you right back.
Thank you to you, the Sickle Cell community,
for inspiring us, partnering with us,
and giving us the opportunity to stand with you, for you.
Our Vertex teams around the globe are proud to be working on sickle cell disease
in hopes of advancing innovative ideas and to make a difference.
And our progress so far is just the beginning.
As we expand our work in this space, we remain committed to our goal
of having a transformative impact on people living with sickle cell disease.
And we continue to stand by your side.